I want to express my appreciation to Dr. Wecht and the organizers of the conference for inviting me to this conference. And I present this with some trepidation because there are many people here who've devoted many years of their lives to studying the material and know it much more thoroughly than I do. But I will tell you my own personal experience of what I saw in the trauma room that day. And then, if there's time, I'll make some other general observations. In November 1963, I'd been a faculty member at the University of Texas Southwestern Medical School in Dallas and on the staff of the Parkland Hospital for 5 months. I had just finished my residency training in neurosurgery at the Neurological Institute, Columbia Presbyterian Medical Center in New York. And Kemp Clark, who was the chief of the department, had completed his training at the same institution several years before, and he'd returned to Dallas to start the neurosurgery department at Southwestern. He'd come up to New York to teach us how to do a certain surgical procedure, anterior cervical fusion, a very common procedure now, but at that time no one at Columbia had done one, and he was a pioneer in that area. Where I had scrubbed with Kemp because I was the chief resident and we became friendly. At Southwestern, neurosurgery was a division of the Department of Surgery. Tom Shires was the chairman of the department. The faculty members were predominantly in their early 30s. There was really a wonderful camaraderie and enthusiasm for taking care of the remarkable range of illnesses that came into Parkland Hospital. And Parkland had become a major center for the care of patients with traumatic injuries. Dr. Shires had developed many of the treatments that became standard for the treatment of traumatic injuries, and in fact there probably couldn't have been a better place to come in the United States if you had a serious injury. Now, at the time I examined the president, I'd already seen a number of handgun injuries of the head, and I'd had 2 years of military service as captain in the medical corps, and I received basic training given to physicians at Fort Sam Houston, which included handling rifles and some information about wounds. And 40 years since, I've been attending neurosurgeon at large urban city-county hospitals, Parkland, Bronx Municipal, John Sealy in Galveston, and Ben Taub General Hospital in Houston. So I've seen many handgun wounds, but not rifle wounds. Few or none of the physicians in the trauma room had seen the type of cranial damage caused by a rifle bullet. And I think this is one of the sources of confusion regarding the president's injuries. Well, on that morning, November 22nd, Kemp and I were sitting in the neurosurgery lab opposite our 2 small offices in the surgery department, and we were talking about the president's visit to Dallas. We knew the president would be traveling in a motorcade through downtown to the Trade Mart, which is about 10 minutes from Parkland. While we were talking, the telephone rang, and I answered the phone, and the voice said the president had been shot. He was being brought to the emergency room. Dr. Clark and I should come. I told Kemp, and we looked at each other, and we said, well, this is just a prank. And several other physicians had similar phone calls that also reacted the same way. But we looked at each other for a minute more, and we decided we better go. We got up and we went to the elevator, and our secretary, Ann, came out of the office and also told us. So we went downstairs and we started running across the parking lot, which was about 100 yards to the hospital. I'll see if I can put the first slide on. No, that somehow is the second slide. Here's the first slide. I took this about a month ago. This is the new Parkland emergency entrance, but it looks very similar to the old entrance. The old entrance was about over here, maybe about 100 feet off to the left, but this is very much the appearance of the emergency room entrance. And we ran down the corridor to the trauma room, to trauma room 1. And this is the current trauma room 1. The old trauma room 1 was also off to the left here, but it was torn down. But this trauma room, still called trauma room 1, looks very much like the old trauma room. It's a pretty small room, actually, and it had the stretcher in the center and had a light above, and various things for resuscitation. And when we got there were a number of physicians there already, all good friends, some of whom are no longer living. Jim Carrico, who became the chairman of surgery there, died last year of lung cancer, of cancer. Jim and Ron Jones, who was a general surgery resident, and Malcolm Perry, who was on the faculty, was a thoracic vascular surgeon, excellent surgeon, had been the first people to examine the president. And as you know, they had found a small wound in the anterior neck, just to the right of the midline, just below the thyroid cartilage. And this was thought to be an entrance wound, which I think was quite a reasonable hypothesis. And the president seemed to be making some agonal, gasping respirations, and he was when we got there as well. Dr. Perry had made a small incision, a horizontal incision, and had done a tracheotomy. We used to do a lot of the tracheotomies in emergency situations in those days. And then Dr. Jones had done venous cut-downs very rapidly. We were also very good at doing that. And they started giving him fluids and connected a respirator. Mrs. Kennedy was standing in the room, and her face was very white, and she was wearing a light-colored suit, and the skirt, the lap of the skirt was covered with blood and brain tissue. It had been noted at that point the president had a head wound, and that his pupils didn't react to light, and that his eyes were divergent, something that you see when the brainstem has been injured. But his head had not been carefully examined, as all the attention had been directed to the ABCs of resuscitation, airway, blood pressure, etc. So Kemp and I went to examine him, and we went behind the stretcher to the head. We stood at the head. Kemp stood there, and I stood over there, just as if I were assisting him at operating. And we lifted the president's head up. It's strange that I cannot remember if we wore gloves or not. In those days, we were not afraid of AIDS in those days, and we would examine many people without gloves. We probably didn't have gloves on. Nowadays, no one would even touch a patient without putting gloves on. But in any event, we lifted his head up, and his head was very thick and brush-like, making it difficult to see a scalp without parting the hair. When we did that, we could see in the right posterior parietal area, and I'll show you where that is in a minute on some slides, the scalp was lacerated and was avulsed outwards. And a large plate of bone had been lifted upward and was protruding from the wound. Protruding edge lay superiorly parallel with the direction of the superior sagittal sinus. The plate seemed to me about 4 inches long, fronto-occipital, and about 2 inches in width. And if the plate had been folded down again, the bottom part of the plate would have come down into the upper temporal area. Medial edge of the plate could not be clearly observed because the brain tissue had herniated outward. The tissue had the appearance of the cerebral cortex. It was macerated, very white. There was no active bleeding. There was blood on the sheets of the carriage and brain tissue. The president was lying supine with his head on the stretcher. Kemp and I then lifted his head to inspect the occiput. There was a laceration approximately 1 inch in diameter located close to the midline of the cranium, approximately 1 inch above the external occipital protuberance. Brain tissue, some of which I thought had the appearance of cerebellar folia, was lying in the laceration. And again, there was no active bleeding. And we did not probe the wounds, and we did not do that in general. We did not put a glove on and palpate or try to feel in the wounds for depressed fractures of any type of wound. Because we thought we would do more damage that way to patients than helping them. Normally we would have x-rayed a patient who had a survivable wound so we could see if there were depressed fragments, but we wouldn't try to feel them, which was a very inaccurate way of doing it. So my immediate thought was that the president had been shot through the occiput and that the bullet had exited through the parietal area. And I also thought that this was a fatal wound. I immediately thought, was there anything we could do to reconstitute the tissue, repair the superior sagittal sinus? But it was clear to me that nothing could be done. Interestingly enough, there was very little discussion among any of the physicians. Everyone was intent upon doing the mechanical things you have to do to maintain a person alive. Everyone's attention was then directed to the problem of maintaining a heartbeat, and no one could feel a carotid or femoral pulse. EKG had been attached using needle electrodes. We didn't have these nice pads we have nowadays, but you just put a needle into the tissue. And there was no organized electrocardiogram. Closed cardiac massage was started, and Dr. Clark did part of that, taking turns with some of the other surgeons. And resuscitation was performed for about 15 minutes. It became apparent to us that the President's heart could not be restarted. And Dr. Clark went to Mrs. Kennedy, who was standing in the room, and comforted her as best he could. And he was the senior surgeon. He was 38. I was 30. He pronounced him dead. The Secret Service was told the President was dead, and there were Secret Service men in the room, but they certainly were not obtrusive, certainly weren't saying anything, and certainly nobody paid any attention to them. I and the other physicians then went out of the room out of respect for the President, out of respect for a dead person, and the nurses who did this task prepared the body. In retrospect, of course, it would have been better if we had totally addressed the President, examined him. We would have seen the back wound. It would have been better if we had made drawings of the wounds. But we went into the hall, and after his body had been placed in a casket, the Secret Service took the body out of the trauma room in the casket, down the corridor to the exit from the emergency room. The county medical examiner, Dr. Earl Rose, appeared and stopped in front of the procession, raised his hands, and tried to stop the procession. And he told them under Texas law that they couldn't remove the body, that an autopsy had to be performed on the body of a homicide victim in the county which the death occurred. But the Secret Service agents were visibly angry. They were furious. They had failed in their job of protecting the President, and they simply took him and just smashed him against the wall and just pushed the stretcher out of the exit. So at that time, we knew that Governor Connolly had been taken to Trauma Room 2. He was being cared for by Dr. Shaw and the Thoracic Surgery Service. We were very shocked by the events. Our immediate concern was knowing what would happen to our country. We didn't know whether the assassination was an initial step that would be followed by a military attack on the country, whether the assassination was due to the Russians, the Cubans, the right, or the left, or some hate group. I don't recall any discussion at the time between Kemp and myself or among the other physicians present about the number of shots that hit the President, the exit or the entry wounds, the bullet trajectories, or other issues that have become of such great forensic interest. Everyone was really too shocked to think beyond the event. Other traumatic events followed in the next 2 days, including the capture of Oswald and his being shot by Jack Ruby. I examined Oswald that Sunday morning, just before he underwent laparotomy. He was in shock as a result of intra-abdominal bleeding, but the general surgeons wanted to know whether the bullet had struck his spinal cord, and my impression was that it had not, and in fact it had not. As you know, there was massive destruction of abdominal contents, large blood vessels. They got his blood pressure up to about 90, but then his heart stopped and they couldn't restart it. Well, I routinely made drawings of the pathological features I observed during operations, and if you went to Parkland and got the old charts out, you would see my drawings of meningiomas, of aneurysm operations, of gunshot wounds of the head, as I'd been taught to do this by my chief in New York, J. Lawrence Poole, who was a really wonderful artist. And I regret now that I did not understand how important the drawings of the wounds would have been in the light of the subsequent uncertainties about the autopsy. But I was caught up in these events, and I had absolutely no inclination to make drawings or write down my observations. Warren Commission called Dr. Clark to testify, and I was not called, but I was content for Dr. Clark to describe the events of the day. In fact, I did not even read the Warren Commission or any of the literature about the assassination until this year, when I started to write this, which is part of an article about the assassination, which is published in the official journal of the Congress of Neurological Surgeons, the journal Neurosurgery. My co-authors are Dan Sullivan, the managing editor, and Rod Faccio, associate editor, and Mike Levy, who is a neurosurgeon, University of California, San Diego, who's been very interested in the autopsy. So throughout the years, I received many inquiries about what I saw that day, but I almost always declined to answer them. An exception was a telephone interview with Ben Bradley of the Boston Globe, who included my comments in an article published in the Globe in June 21st, 1981. And Mr. Bradley described the discrepancies in the testimony and the autopsy findings regarding the location of the President's wounds. It was a synopsis of interviews with 14 doctors and nurses in Trauma Room 1. In 1997, Douglas Horn and T. Jeremy Gunn, who are on the staff of the Assassination Records Review Board, interviewed me at my office in Houston, and they brought copies of the autopsy photographs and drawings, and I made drawings of the wounds as I remembered them, and they also tape recorded my interview. And this is what I drew for them, and this is my recollection. This is the standard anatomical plate of the back of the head, and I recall a wound here through which I thought the cerebellum, and I told people that I thought I had seen the cerebellum, my friends at the time, and that the bullet had gone this way and exited that way. Next slide. Here. And this is where I saw the blasted out bone. This was clearly an exit wound of bullet fragments and the explosive contents of the brain driven out by the tremendous pressure that develops in a skull when a bullet is fired into it. Now, are there problems or discrepancies? Yes, there are. In looking at the photographs, at least that are available to me, of the back of the head, I cannot clearly see an entrance wound in the occipital area. In 1972, Dr. Wecht was the first pathologist to examine the autopsy records in the National Archives, and he pointed out, in his really very fine article, that the occipital area shows a small area in the lower scalp which has a blemish. It's sort of a reddish mark. Could this possibly be an entrance wound in the scalp that had been cleaned and combed, the hair combed down? Possibly. Dr. Baden is going to talk to us, and the Clark panel and the House Select Committee panel that he chaired identified an area higher up near the so-called cowlick that could conceivably be an entry wound. But I would say for myself, I would like to have the opportunity to see whatever photographs still are available to try to make my own mind up. And I would say the same for the x-rays. I'll show you one of the x-rays later on, but let me go on now and make a few other sort of general comments as to perhaps what could a neurosurgeon add to the analysis of the wounds. I went to Dallas, actually for the first time that I've ever been in Dealey Plaza, even though I lived there for many years. And this is taken from where the headshot was, and we see the 6th floor window, and we see some other windows. The trees were not as high then, but we see some other windows. We see a window on the west side, a low window. Several other places gunmen could have been. We see the Daltex building. This is about another 100 feet farther on than this site. But there are several sites, but there are actually not too many sites from which a gunman could have shot, or several gunmen could have shot. This is a view of the so-called sniper's nest or lair with the boxes piled up. I think we do not know if the boxes really were in this position exactly on that day. They seem to probably have been moved around a bit. And this, just for those who might not have seen this, if there are such people here, is a view not from the sniper's lair, but from the window next to it, as you can't go into that room anymore, just showing approximately, that car is approximately at the spot where the headshot occurred. This is a view from behind the picket fence on the grassy knoll. I think you can just see the X that marks the probable headshot site. This is about 100 feet, as someone said this morning as well. I think for a gunman to have shot from here, you can't shoot between these slats or pickets. You'd have to have the barrel of the rifle extending out into the grassy knoll area, and you'd have to do some tracking. The limousine was traveling about 15 feet per second, so the gun barrel would have to protrude and track to shoot from there. This is a drawing I made showing some angles. This is the Texas School Book Depository, and this is the 6th floor window. This is the axis of the limousine. And this is about a 10-degree offset from the axis of the limousine. A shot from the west window, 2nd floor, is about 28 degrees. And this is actually not a very good place to take a shot from, because you can't see the limousine coming unless you had someone with a radio controlling you. This is actually an excellent spot because you could see the limousine coming down Houston Street and turning, and then you could track it quite a distance. Here you could only see the limousine for a rather short time until you had the opportunity to shoot. Here is Zapruder, 75 feet from Zapruder to the X in the street. And you can see also how close it is from the picket fence, grassy knoll, to Zapruder. This is only 60 feet. So as people have said, this is actually quite a small area, though the impression you get when you do reading about it is that it's much larger. It really is quite small. What else could be thought about or contributed? What I've tried to do here is perhaps put down a framework for thinking about this, because people have asked, well, what could come out of this symposium? What new things could come out of it? I think one thing that could come out of it would be some sort of generally agreed upon framework of discourse. And this is a diagram which I think, I'm not claiming it's correct or even original, but I think it provides sort of a framework of discourse, because everyone seems to have a different framework. You might think of this as like a map of a chromosome. Where are the genes located? The genome has been published, but even the people who published it don't agree completely about where the genes are located, but at least they have a common map and they can discuss it. And what I did was I went up there and I took a GPS a device, and I took a laser rangefinder and I measured some of the distances at angles. This is the height of the Texas School Book Depository, and the 6th floor window is at about 60 feet. Elm Street declines about 17 feet over 300 feet, and it is a 3-degree angle, as the FBI said. I measured this with another device. There are different spots where people have claimed that different wounds occurred. I would just concentrate over here at this point. This is where the headshot, I think everyone agrees, at. And I measured 273 feet. The FBI measured 270 feet. I think one of the things that could be done if this were to be reinvestigated would be to have really professional surveyors resurvey all these angles and distances. I obtained an angle from the window to the locus of where the head was, which is probably about 5 feet above the pavement. I obtained a 12-degree angle. The FBI obtained a 15-degree angle. Here we have the Zapruder frames correlated. Here we have the wounding site according to various things, such as the Zapruder film, back and neck, which I think occurred perhaps around 224. Other people might have thought it was behind the freeway sign at 210. Other people might have thought it was even earlier. We have some times calculated backwards from the headshot. Now, are these correct? I wouldn't say they're correct, but I think I've never seen it laid out clearly this way before, and I think this is absolutely needs to be done if there's going to be any sort of resolution. Finally, what else might a neurosurgeon be able to contribute to this by a neurosurgical viewpoint? I will go back just a few films here and say the way a neurosurgeon looks at the head when it begins to operate is that you establish a normal baseline. This we do when we do so-called stereotactic surgery. There is an anatomical baseline of the skull which involves drawing a line from the inferior margin of the orbit through the external auditory canal backwards. This is called Reed's baseline or the Frankfurt anatomical plane. And this line comes out always about a centimeter, within a centimeter of the external occipital protuberance, also called the inion. And so this is, if you draw this line on people, this is parallel to the ground. People carry their heads so that this line, if the people are healthy, is parallel to the ground. So if you want to know the position the head is in at some point, say when the person has been shot, you need to construct this line. And that is what I've done here on frame 312, which is an 1/18 of a second before the fatal shot. And you can see the line is going from approximately the external occipital protuberance of the inion through the external canal, through the orbit. And this is 26 degrees tilted downward with respect to the side of the limousine. And the limousine, we know, is tilted downward 3 degrees to the horizontal. So I think we have to consider this in any discussion of the president's head wound as to where was his head when he was shot. What I've done here then is to take the skull film, the lateral skull film taken presumably before the autopsy began, and put it in that position. This is the orbital rim, this is the external canal, this is the external protuberance. I've tilted this down 26 degrees with respect to Elm Street. And then I have drawn 2 entry wounds. One at the autopsy entry site, which is about 1 centimeter above the external protuberance. This is a line at 12 degrees. And here is the Clark, Dr. Baden's panel site. You notice this, how the skull is lifted off there at that point is going forward. And this is the area which I recall having been blasted out. So I think this is something for us to consider and think about when we think about the wounds. I will make one other comment. If you notice how dark the skull is in front here, and people have made the comment, this is obviously, the skull is obviously missing at this area because it's totally black or dark. This is not the case. You show this to any neuroradiologist, they'll tell you that this is an artifact of the windowing or the imaging. These images of these x-rays were digitally enhanced, and it's very easy to produce this. You could do this at home on Photoshop by taking a skull film and simply changing the contrast or the windowing. The bone in the frontal area is thinner, and you can make it disappear. You can see on x-rays various holes or dimples. People have said these are entrance wounds. These are not. These normal appearance of the occipital area of the skull. Also, there was air inside the skull in this area, which also makes it less dense. So those are, I think, perhaps some things that a neurosurgeon could contribute to the analysis. And I would say, finally, besides trying to develop some sort of common framework for discourse, I think it would be very important if people who had serious interest in studying this could have access to the original X-rays and to the whatever photographic images are available. Thank you very much.